We'd like to welcome you to the Healthcare Revolution podcast, where we empower you to take control of your health, restore your trust in the medical system, and achieve lasting wellness. I am your host, Brad Powell, Doctor of Physical Therapy and owner of an award-winning foundation physical therapy here in the Salt Lake Valley. Each episode, we dive into all things rehab prevention, overall health, bringing you expert insights from leaders across the healthcare fields. Please note, while we aim to provide with the best knowledge and advice, the opinions shared represent those of experts in the field and are not to be replaced with professional medical advice. So let's revolutionize healthcare and wellness together. Welcome to the podcast this morning. We have a very special topic to talk about today. Many aging parents need medical help at one time or another. And when this happens, families typically get overwhelmed. They're uncertain about the future. And our medical system, typically fails these people quite a bit. And today I have one of my good friends, Steven Schiess, who is an absolute expert in geriatric care with older adults, making sure that they have the right advocates and things in place to be able to have the most successful outcomes. Because many older adults, they fall through cracks, they have rushed appointments, they're fragmented communication, things are not aligned, and we just have outdated care models within these facilities with skilled nursing facilities, home health, assisted living, and they just fail to really honor the dignity and the potential of these older adults. And we want to improve that. Yeah. And Steve is a strong advocate for that. I've loved and respected him for so long. I'm so excited to have him on. I'm just going to tell you a little bit about him, and then we'll talk about a little bit more about the podcast today. But he is a nurse practitioner in skilled nursing facilities. He oversees really 14 different clinics across the state and does home health as well, really kind of guiding the care of these older adults. He's a relentless advocate for this population. He is a dog. He will go fight for these people. He'll advocate for them, get them the care that they need. He's been doing it for over a decade, and there's no one that knows this system and how to guide it better than him. He just builds bridges in healthcare. He breaks down walls, and he's really challenging the status quo, and he's aligned with what we do here at the Healthcare Revolution. So excited to talk about him and to dive into all the essential things that these older adults should need, and knowing how to protect them, how to advocate for them. So we're going to dive into all these tips today. So welcome to the podcast, Steve.
Thanks, Brad. It's good to be here.
It's so excited to have you here. Tell me, as I did that introduction, tell me what story. Just give me a story that comes to mind about maybe an older adult that's fallen through the cracks or the system hasn't served them well. What comes to mind?
I think one of the biggest things that comes to mind is that when people are doing these different transitions from hospital to skilled nursing facility, they often just don't understand the differences, and they don't understand their insurance, and they don't understand what's covered and what's not covered, or what they can do and what they can't do. And I run into it all the time that there's this thought process of when people are on Medicare, that Medicare covers 100 days in a skilled nursing facility. Well, the caveat to that is that plans typically only cover patients to be in a skilled nursing facility for 20 days, 100% full covered. After 20 days, they have a copay, and that copay comes from either $100 to $400 a day that they have to pay to stay there to receive further help. But no one tells them that. So when they get there, they're like, oh yeah, I'm covered for 100 days to get all my care taken care of. And you really have to communicate with them. And, I had a patient just last week that he was like, yeah, they say I have 100 days. And I'm like, those 100 days, that full covered 100 days ended just like last week. Now it's a full coverage for you. Well,
what's full coverage?
Which is $700 a day at some of these facilities. And you have somebody that has a fixed income, that's impossible for them to do. And so it happens all the time. That's kind of one of the number one things is that we see in a skilled nursing facility, is that it's not as cut and dry as what they make it seem like it is.
Yeah.
These patients come in, they don't really know what's covered. They don't really know what help they're going to get. They don't know what the future looks like afterwards. Many of them are coming in with just life-changing medical problems. And the gravity of that sometimes is what's sad to see, that they don't understand that this is, someone comes in with a cabbage times by 4.
Tell us what that is.
That's a heart condition where they have to go in and they have to open up the veins and the arteries and make sure that stents are placed and that the heart is working well. Well, that's a life-changing surgery.
Yeah.
And people come in and they're like, yeah, I've got 100 days to stay here, right? You've got 20 days fully covered. And after that, you have to pay a copay.
Tell us, all the complexities of this. Keep going, because I think a lot of the public doesn't understand why this becomes so complex, because you have open heart surgery, with all these different medical complications. You have people that are already frail,
Right.
They're weak, they're already not taking care of themselves. Then they have open heart surgery, and then it's like you're in a skilled nursing facility. You got 20 days. We're on a time clock to get you out, right? Because medical coverage, if we don't, you're going to have a huge financial bill, right? So you just think about that complexity. What other complexities do we have here?
I think as well, with these complex medical conditions, understanding that, and this is something for families to understand too, that plan A of getting mom or dad back to where they were prior to their complex medical problem in the hospital may not be the safest option for them, may not be the safest thing for them. We, as humans, we are routine, right? So we get mom and dad back to where they were before, and oftentimes they're going to fall into old routines. Not exercising, not having good nutrition, not taking care of themselves well. If they're by themselves and they have cognitive difficulties, are they going to remember to take their medications appropriately after these complex medical things? And so I think it's, making sure that you are communicating with your loved ones and understanding what their desires are, but also understanding that mom and dad's desire to be home by themselves when they can't walk and they have stairs that they have to navigate, or they can't remember to take medications, but they want that independence. You kind of have to give this, it's kind of a take and, a give and take a little bit, right? That might be great. I love patients to go home if it's safe. And going home might not be the safest option. So what is option B?
Yeah.
What is option C?
So my first internship in physical therapy school in my doctoral program was in a skilled nursing facility. And I remember as a young graduate student walking to that facility, and I'd hear all these terms like SNF and IRF and ARC and like all these just random acronyms. I'm like, I don't even know what you guys are talking about.
Right.
And for those who don't know those words, SNF is a skilled nursing facility.
Right.
And IRF is what?
Well, the inpatient rehab facility.
What's the difference between inpatient rehab and skilled nursing?
I would say the resources that are available.
Yeah.
And I would say the nursing ratio and the staff ratio. That's another big misconception, right? You have a hospital and your staff ratio to nurses when I was working the floor was 4 to 5 patients per nurse.
Mm-hmm.
And 7 to 8 patients per CNA.
Yeah.
And you've got 24-hour care. You've got a hospitalist on call. You've got all these things. You've got stat labs. You've got stat x-ray. See, you name it. I write an order in the hospital and it's done within 5 minutes.
Yeah.
You come to a skilled nursing facility, and that's a big misconception is, well, in the hospital, I called and they were there within 30 seconds. Okay, staff ratio of nurses in a skilled nursing facility, 1 to 12, 1 to 15. Staff ratio of a CNA or a nursing attendant to a patient, 1 to 15, 1 to 20 sometimes.
Yeah, so you think about that ratio.
Nothing is the same.
It limits our ability to get to the patient, right? So if we're just talking, say your loved one gets an open heart surgery, the cabbage that we were talking about, where they're going in, putting in stents in their heart, and it's a very complex they've had to cut open the chest, break the sternum, and do those repairs. And then typically they're going to go to an inpatient rehab facility for a few days where they have the ratios really, really good. Right. Of these medical providers, there's an internal physician that's checking on you once, if not twice a day. You have a nurse, probably 1 to 4 or 5 ratio. They're watching over 4 or 5 people. You can hit that call light. People are with you. You typically get, if I remember all the logistics here, you get an hour or 2 of physical therapy, occupational therapy, and speech. I think it's an hour each.
Inpatient, right? Inpatient is 3 hours total per day per patient of all of those things. It could be just physical therapy, it could be occupation, but it's a very intensive program for a reason, right? We want to get them out of the hospital and back home as soon as possible, safe and rehabilitated.
Yeah. And we're going to break down the pathway real quick. So we got hospital, you get the surgery, it might be the ICU, then the medical floor, and then your transition to typically a inpatient rehab if you're medically complex.
Yep.
And then from there, 3 to 14 days, you're graduated to either home or a skilled nursing facility.
Correct.
And then from what you're saying, 20 days is most insurances for full coverage, and then up to 100, but you're paying a pretty penny.
Correct.
And then tell us what patients go to home health, and then let's talk about assisted living after that.
So the number one thing that my group, the practitioners that are in my group and that I'm concerned about is safety. Is it safe? Is it safe for your loved one to go back to where they were prior to the hospital? And safety could mean many things. Are they safe cognitively? Is mom and dad remembering things? Are they able to pass a MOCA score, which is a Montreal Cognitive Assessment Score? We use that in therapy all the time. We use that in nursing all the time. And basically what that does is it gives us executive functioning skills. So as mom and dad, for example, the example I give my patients with this cognitive test is you get out 2 pieces of bread. You want to make a grilled cheese sandwich. Get out the bread, get out the cheese, layer it on, put the butter on the bread, turn on the stove, put it on the hot pan, cook your sandwich, take off the sandwich, sit down and eat. Well, what step did you forget to do? You forgot to turn off the stove. Now, to one of us, we'll most likely come back around and be like, oh, I forgot to turn off the stove. Mom and dad might sit down, eat their sandwich, and go to the bathroom, and that stove is still hot and burning. And it's a safety hazard. And they may never remember to turn off the stove until someone else comes in and does it for them.
Yeah.
That's an executive thinking skill. That's something that promotes, is mom and dad safe to be home? Are they safe? Do they remember to turn off the water when they're in the bathroom? Or do they get onto something else? And that's nothing against mom and dad. That's just sometimes a natural part of aging is that cognitive skills just start to decline. So we do the MOCA on them and we say, okay, out of 30, where are they? And typically on that scale, if they're below 20, we're like, there's some executive thinking skills that are not safe for mom and dad to be home alone.
Yeah.
So we look into that. Do we say, okay, are they cognitively safe? And I use the MOCA mostly in my patients. There's other tests, but I usually use the MOCA. Is it safe for them physically? So we have to kind of do a home safety eval and be like, okay, mom and dad have stairs, but they're not walking up them very well at the skilled nursing facility.
Yeah, it's so easy for, a family member to look at this and say, well, my mom looks great. She's ready to go home. And as providers, we're like, okay, we understand her prior level of function. That's not currently what we're seeing.
No.
This is the criteria, both physically, mentally, cognitively, that we would need to pass in order to go home. It's not that we're being rude, or we don't want them to be independent. We actually do want them to be independent.
100%.
But we, more importantly, want them to be safe, because we don't want them to come back to the hospital system. Because when people fall, I worked in a hip fracture study for 3 years in PT school. when people fall, I can't even remember the percentage. It was like 75% died within a year.
Yeah.
Like,
it's
so
a huge percentage.
we are trying to completely diminish the chances of a fall happening. You fall and break your hip, get pneumonia. There's a very small percentage you're returning from that.
Well, and you have to remember with these patients, I always talk to them. I say, okay, day 0 is the moment you broke your hip. Not prior. Day 0 is right there. This might be your new reality. Now, where do we work from here? You're improved in the hospital. Great. We got it fixed. Great. Now we're off to next step, which is physical therapy, heavy physical therapy, making sure that we're getting that rehabilitation and that movement and that range of motion back. Awesome. Now, where's your cognitive with that?
Yeah.
Where's your medication? We haven't talked about medications yet. Where's your polypharmacy?
Yeah,
polypharmacy, too many, which basically means too many meds at too high of doses that could be causing your mom's fall, or could be causing dizziness, or could be, having all these signs and symptoms of different health conditions. And it may not even be a health condition. It may be caused by the medication. Mm-hmm. And that's a completely different thing that we have to talk about.
And that's why you need the medical team, because initially with medication, you might be on higher dosage for your family member. And then it's really important to be dosing off of some things and dosing on to others, right? And if you got... I was in the hospital. People were taking like 10, 15 medications a day. I'm like, how does anyone full-time, like this is a full-time job just managing their meds.
Okay.
You know what I mean? And some are really important and life-saving. And if we're not managing them well, imagine if they have a cognitive deficit.
Correct.
Or memory deficit, and they're supposed to take them 2 times a day by mouth.
It usually doesn't happen.
Yeah, and it's life-saving if they're taking it, or life-threatening if they don't. But you think that your loved one has the cognitive ability, but you can't see these cognitive deficits.
Yeah.
So that's why it's so important to have criteria to know people are ready, rather than just say, it's been time.
Yeah.
They seem like they're back to themselves.
Right.
No, we do tests. So each phase of the hospital system or healthcare system is important to pass the criteria before going to the next phase.
Oh, and it's that old adage of, 2 sets of eyes are better than 1, right? Thinking about my own family, my dad passed 2 years ago, and trying to help him navigate his healthcare system, navigate his complex healthcare problems as a son was really hard.
Yeah.
And as a provider was even harder.
Because you're like, I just want to step in here and solve this.
Yeah. But you can't.
Yeah.
You can't because... and that's another complex problem to get into, is that dynamic of family versus caregiver is a sad one oftentimes.
Yeah.
I think about my dad, and I wanted first to be a son, but B, I knew what he should be doing as a caregiver. As a healthcare professional, I knew what he should be doing.
Yeah.
But I wanted to keep that relationship. And oftentimes when a family member becomes a caregiver, a relationship changes. And that's a really hard dynamic to get used to.
What advice would you give family members that want to be the caregiver? I know it's a very, very torn and fragmented and based off of the individual circumstances, but what tips would you give these families that are like, we're going to go in and we're going to take care of mom every day and we're going to keep doing it for years to come? What advice would you have for them?
I had a patient just recently that I helped with this. Something I do as a provider is I sit down and have what are called IDTs, or interdisciplinary teams.
I love those.
Okay.
They're so good.
And number one,
if you don't know what these are, really listen to this. This is
number
good.
one, if your caregiver goes in, if your loved one goes into a skilled nursing facility, ask when the next IDT is going to be. And what that is it's a meeting that we have, at least the way I run them is I'm there, the discharge planner is there, the physical therapist is there, the patient is there, and the family members are there. Mm-hmm. And maybe there's a couple nursing manager or something that's there as well. in between, and maybe occupational therapy.
And you would say most skilled nursing facilities run interdisciplinary team meetings, right?
Yes, I would say sometimes you have to ask for them.
Ooh, definitely ask for these.
We're
going to talk about the specifics of these, but these are absolutely critical to getting everyone aligned on the next steps.
Yes.
So let's tell me about them.
So I had this meeting with this patient and with his family, and I was like, okay, so patient fairly independent prior to coming to the skilled nursing facility and having his problem at the hospital. Fairly independent, right? But there were definitely some cognitive issues going on that we found on the MOCA, that you could see on assessment. Like, it was evident. And family knew this as well. So patient wanted to go back to home. Of course, who doesn't want to go back home? I love home, right? They do too. But we could see that him going home put him at a really great risk for returning to the hospital. And so having this IDT with family, I was able to sit down and be like, okay, you want to go back home, patient. Let's work towards that. What deficits do you have at home? Let's do a home safety eval. Physical therapy, I need you to do a home safety eval on this guy. Okay? And his home. Family, he wants to go back home. How do you feel about that? And getting that honest communication between patient and family in a mediated type of an environment is really important. These are
conversations
because
most people have never had.
Right.
Like, we haven't even talked about this. All right, well, let's get it on the table.
And I'm an advocate for patients, but I'm also an advocate for how family feels as well, because if family's stepping in as the primary caregiver, I've been there. I know how that is. And so I want to make sure that their wishes and their concerns are expressed as well in a nice, safe environment, right? So what are your concerns? Well, Dad's great most of the time. But this most recent time, he was on the ground for 48 hours and never called us and just felt like someone will check on me. And we eventually did, but he never called us. So what can we do, Steve, to help prevent that in the future? Well, let's talk about options. Do we need private caregivers in there? So yeah, you want to go home. You can't afford assisted living or don't want to pay for it because that's not covered by insurance. But maybe you can pay private caregivers to come in once and 1 hour in the morning and 1 hour at night. And the other thing that does...
What I love about these... Go ahead and finish what you're saying first. What do you love about
the one thing that does, having private caregivers in there, is that gives the family a break. Mm-hmm. So family can be family, not just caregivers. Mm-hmm. And they can still maintain that relationship status with their loved one. And it also provides the patient some socialization with people other than their family, which is really important.
There's so many benefits to that.
Psychosocial, making sure that they're not isolated, is extremely important for healthcare with the elderly and the geriatric patients. So, I mean, having these IDTs, I think, is probably one of the most important things you can do if your family member goes into a SNF.
Yeah. And I want to just kind of paint the picture here. You're sitting at a conference table. You got mom who had a broken hip, and now she's in a skilled nurse. So you got her in a chair here. You got 3 of her daughters, right? And you got the physical therapist, occupational therapist, discharge nurse, maybe speech therapist. Who else are we missing at the table here? Did I cover everyone?
Pretty much covers them.
So essentially,
dietitian sometimes.
Yeah, dietitian makes sure they're eating, they're getting the right nutrition. But you have all the key players sitting at the same table, from their expertise, sharing what their concerns are. It's like X, Y, and Z. They did good at this. They did great at this. This is my concern in this area. I remember as a PT student, I was empowered by my clinical instructor to lead the discussion.
Yeah.
Like, she can do everything other than stairs, right? I've passed her off on everything. We need to keep working on stairs. My recommendation is 3 more days. That'll get us what we need, I believe, based on a progression so far, to be able to navigate the stairs appropriately. Keep in mind, mine's the physical.
Right.
We come to the speech therapist who's measuring cognition, and they're like, memory is not where we need it to be. I'm worried about her, having unsafe conditions because she's forgetful, right? Then the daughters are over here like, oh my gosh, I did not even think about that. I was just thinking about her physical, right?
Right.
And then you go to the nurse, is like, okay, we're having a hard time managing meds, right? So this one person might be given the pass off saying that they're safe to go home, but another person is like, nope. And then maybe one of the daughters has got a key piece of information that mom's wishes, or maybe mom isn't speaking up and she's like, I really just want to go to an assisted living center. I don't even care to go home. And all the daughters are like, no, we want her home because we believe that's what she wants, but no one's ever spoken it, right?
Right.
But we sit at this conference table together in a mediated situation with all these experts and saying, what is the best thing for this patient and for your family?
Right.
We are going to advocate strongly for you. We're going to give you the best solutions, but there's about 100 different scenarios. And what we talk about today on this table will determine the best scenario for you. But you have all these experts here. Use this as a resource. Let's go. Right?
Yeah. Well, and just so families understand that hospital-based care is acute short-term stabilization care. Okay? Skilled nursing facility care is long-term. So when I talk about mom not being ready to do stairs right now, that's a true statement. Acutely right now, she's not ready to do stairs. Doesn't mean she's not going to get there in the future. But we have to work towards the future. So everything that I do for my patients is not, 2 weeks out. Everything I do for my patients is I'm looking 3 months out.
Yeah.
And if 3 months out does not look good, for her to be at home because it's not safe and she's at a huge high risk to go back to the hospital because XYZ in the home is not safe for her to be there, then I'm going to recommend something else. I'm going to recommend we look at a plan B like an assisted living. We look at a long-term care skilled facility. We make sure that you're getting those resources. I'm going to recommend you call 211, which is the state resource, and ask for elderly care. And get a case manager to see, can mom get Meals on Wheels? Can she get transportation to her places?
And that's such a great resource that people don't know about,
They
right?
don't know. They're like, well, and, what resources do we have? What is it just
These
us and the private caregivers?
Taxes are paying for,
yeah,
right?
You're paying for these things. And those resources are out there. But I'm going to recommend certain things. And I think when you come into these IDTs, when you have a family member in a skilled nursing facility, remember that we're on the same team.
Mm-hmm.
Just because we say something that you perceive negative about mom's physical ability, it's not negative. It's realistic.
Yeah, how many patients or caregivers or family have you heard say, well, I know my mom and she'll overcome this?
All the time.
Well, sure, she'll overcome it.
All the time.
But how much suffering do you want her to go through?
Yeah, quality
right?
versus quantity.
Like we are really, as a team, focusing on the quality of your mom's health for years from now. Correct. We're not just worried about the next 2 months. We're worried about what longevity looks like for the next 10 years.
And, that's a hard conversation to have with family.
Longevity and more quality.
Right.
What's the quality of life look for her? How can we maximize that?
Yeah, and that's a hard conversation to have with family. I was thinking the other day, in the month of November and December, I think I've put about 8 to 10 patients on hospice. It's a lot of patients to put on.
Define hospice for us.
So hospice is basically end-of-life care. Then you have...
So you've been to skilled nursing, you went home, maybe had home health, things are just not looking well. The nurse comes in, does an evaluation, and says, we're deeming this a hospice case. Is that how it goes?
Yeah, typically. Well, and I've put them on it from the skilled nursing facility. Mm-hmm. They've come into the skilled nursing facility with some sort of, not great chronic condition. For example, an older lady that had unstable pelvic fractures that they weren't able to operate on. And she's unable to move. She's not getting out of bed. Son wants her to move and transfer from the bed to a bedside commode so he can get her home. it's not feasible.
Yeah.
She's in pain. There's nothing we can do for
she literally doesn't even want to
unstable
move
fractures.
her leg.
She doesn't want to move her leg. We've tried medications, but how do you put a person that's over 100 years old on high doses of oxycodone? You don't, because you want some of their cognitive to be there. You know, do you completely sedate her? Well, that doesn't help us with physical therapy. You know, ice isn't working. There's a language barrier. Like, there's so many different scenarios in a case like this, but I've had to been like, okay, what do you think your mom would want? If you take her home, she's at a high risk for pneumonia. She's at a high risk for blood clots. She's at a high risk for bed sores. This is what reality is going to look like if these things happen. So,
and they happen like this.
And
they're so quick.
Right.
Like, you think that they're good, they look strong, and then all of a sudden
they're down.
And then things get compounded. You get a bed sore. You get pneumonia.
Infection sets in.
Yeah, a bed sore can happen within a couple days, and it's a wound that can happen on the anywhere on your butt, on your bottom, anywhere on your hips, right, from pressure points from
mostly
laying
those bony prominences.
And then all of a sudden that gets infected. The bone gets infected. Then it becomes all across your body, systemic, and that's it.
Yeah.
Right. So these are the things that are going through our heads when we're talking about quality of life, and our worry when we say, let's maybe think about this direction as well, because we don't want your mom or dad to go through all of that. Yeah. Neither do you. You just don't know what's coming ahead.
Yeah, I've always told my patients it's hard. I don't have a crystal ball to tell the future, but I can tell you right now what things look like. I can't tell you what decision to make, but I'll give you my personal opinion. I'll give you my professional opinion. I'll give my opinion of somebody that cares for your parents. I care for my patients. I want them to know I care for them. I want the families to know that I care for them, because this isn't just another person.
Yeah.
To me, these people are in my community. They're members of maybe my same religion. They're family members of people that I know. It's different.
I love that about you, Steve. You care so deeply for these patients, and I have so much respect for that, because I feel of that empathy. I feel of that connection with you, because these people need advocates.
I do.
You know, like they need these people that are going to go fight for them, because unfortunately our healthcare system, it is fragmented. There's some things wrong with it. And if we don't have people like us that are in it with them and advocating for them, it doesn't improve. You know, and I'm so grateful that you are there for these people, their families, advocating for them, and giving them your personal best and your professional best, explaining, like, these are the routes that I've seen. I love what you just said. Like, I don't have a crystal ball of what your future looks like for your mom or dad, but I'll give you my best information that I have. And that's what we have to operate off. You know your parents. You hopefully know their wishes. And I'm going to help you through this process the best that we can. What advice do you have to people right now that maybe are not going through this yet? What conversation should they be should be having with their parents? What advice do you have there?
Have a conversation with your parents. Have a conversation right now when they are cognitively with it. Because inevitably, the majority of people that I see in skilled nursing facilities have some sort of a cognitive deficit. Not always, but more than most have some sort of a cognitive deficit, whether that be executive functioning like we talked about before or something. And have that conversation now so that you can, and it's uncomfortable. No one wants to think about their parents dying. No one wants to think about their parents getting to that age, nor do the parents, right? Having that conversation with my dad 2 years ago before he died, I don't want to think about that. And I was thinking this morning, have I had that conversation with my mom? No, but I'm going to. It's an uncomfortable conversation to have, but it can help in the future when we don't know the future. It can help drive some care and get things in place and just start thinking about things. Well, Dad's not 45 anymore. He can't navigate. Oh, wait, Dad is a little bit wobbly sometimes. Noticing that. If you want to be an active participant in your parents' care, start noticing that. Start getting involved now, not overbearing, just being there as a support for them. And understanding that inevitably, death is the thing that connects us all. Aging is the thing that connects us all. It might be the one underlying thing that connects every person in this world. Aging. Everybody ages. So how can we best support everybody that ages, including ourselves?
What would be your recommended questions to ask your parent today to prepare both sides? What would you say? And maybe give us an example with your mom. What are the questions you're going to go home and ask your mom?
I think if I was to go home and ask my mom right now, I would ask her, Mom, not if, but when your body starts to decline, what do you want us to do? What do you want to have happen? Because you can't just say, well, I'm good. I'm never declining. That doesn't happen, right? What do you want us to do with the home? It's your home, not mine. But how can I help you with that? How can I help you? Are there things that you're concerned about right now? Asking them that honest conversation. We have that conversation with our kids all the time. Why can't we have it with our parents?
Yeah, where do you want to go to college? What do you want your career to look like?
Right. We have these conversations all the time with people all around us. But when it comes to our elderly parents, I think we're nervous because
you're switching roles from
right.
They were your parental figure.
Yeah.
And now essentially the roles have switched in which you were maybe be taking care of them, right? Rather than them taking care of you. So it's kind of an awkward place to be in because you haven't been trained on it.
Right.
Just like becoming a new parent, you're not trained on becoming a new parent. You're kind of just forced into it, right?
Right.
But these are so critical questions to be asking before you're in these situations.
Well, and I think about, it just came to mind, there's been multiple experiences that I've had in the last year and a half as a nurse practitioner and prior as a nurse where, something life-altering comes up and the family members don't know what to do or don't want to get involved. And that is a really sad case when I have to send someone home with zero options because A, they may not have things saved up to go and get private caregivers or go to an assisted living, or B, they don't have insurance, or C, they're homeless, or one of these things. And I have to discharge them home to the community with a prayer that something will go right because there hasn't been things set in place. There is no plan. It's just living day by day. And unfortunately, our healthcare system kind of forces people to live day by day. They don't know what their next paycheck's going to be. They don't know if they're going to get Social Security. They don't know if they're going to get health insurance benefits, things like that. But I would say if you as a family member can just have an honest, open communication with your family and be like, what are your wishes? Do you have wishes? What are your desires? If I find you down, do you want me to do CPR on you at age 88? Educate yourself a little bit about what your parents...
How often does that happen, right?
All the time.
My wife's grandma ended up coding on her front doorstep. And her cousin, who was 25 years old, did CPR on her. He, just to paint the picture here, 25-year-old doing CPR on I want to say late 80-year-old, breaking her chest, right? Because very fragile bones, very osteoporotic. And grandpa comes out and knows the wishes of his wife and says, stop, everyone stop. She doesn't want to be resuscitated, right? And that's hard because you have family that's sitting here like, well, we want to save mom's life. But only grandpa knew the wishes, right? Not everyone else did. And that was a really traumatic experience for a lot of people. And ultimately, it was going to be traumatic anyways, right? Death is inevitable. It's part of the human existent process. But I think a lot of that can be very peaceful moments when everyone really understands the wishes of that individual. I was just talking to my wife this morning about my wishes. We were joking about, how many head injuries I've had and how I'll go out. Like, she made a joke like, you'll be here, but you won't be here, right? Right. So, we had a brief conversation about my wishes, just not even in preparation for this conversation. It was purely, we continue to have those because they're important, right? And how peaceful would it be if you knew the wishes of that person before you even got there, right?
It would be amazing. With these experiences I've had with these hospice patients recently, and I've become good friends with the family and with the patients because we've had honest, open communications about what mom or dad want. And as I think about a couple of these experiences, it was so peaceful and in some ways uplifting when I went in for that discharge appointment before a hospice care took over. And I was able to talk with the family members and talk with the patients and have an honest, open communication, not about their chronic health condition, not about, even what to expect next, because we have been over that, but we talked about who they are as a person. And the one question that I have asked my hospice patients in the last month and a half is, what is your greatest accomplishment? Now, that's coming from a provider who I probably should be focusing on provider stuff. But that person wants to be known as a person, that connection. We're making that connection as a provider, but also as a person.
Let me repeat that question. She said, what is your greatest accomplishment is what you're asking people.
Correct.
What do they say? What are kind of like the, because everyone wants to know that. Like, as you're in your last breaths, are you concerned about the money? Are you concerned about like all these things that we all stress about? But what are these people saying in their last moments?
Family.
Their greatest accomplishment was their family. I love that. And
it's been and I've written these down in a journal that I'm keeping just as I go through these hospice experiences, just because I want to remember these people for who they are and remember these people that they are people. They're not just patients. If we can build that connection, if I can build that connection as a provider, I think I'm doing something right. I think that, and those people deserve that dignity at the end of their life, that they don't just be remembered as a patient, but they be remembered as a person.
Yeah.
But overarching, it's that family. Family is what matters important. So I would say to the families right now, make it that conversation, because your parents need that help. Your parents want you more than likely to be somewhat involved.
Yeah.
They just don't know how to ask you. And if you don't know how to ask your healthcare providers, how do I have that conversation? So that we can all be on the same page. So that when we get to that end of life, it's a dignified conversation about life, not anxiety and fear about what's going to happen. We've already had that conversation. Yeah. We know what your wishes are. You want to go out in style? Let's do it.
Yeah.
You want to have that help? Let's do it. Let's provide those resources for you. But it's been an amazing experience. I didn't ever think as a provider that I would enjoy having the geriatric population, but I don't go anywhere else.
Yeah.
It's where I'm supposed to be.
I love it. And you're dang good at it. So let's see if we can summarize the conversation that you would have with your family member. What advice would you have for family members to have this conversation with their mom or grandma or dad, their loved one?
Make a plan. Have plan A, B, C, D, E, however many you have to have. But make a plan. just to have something in writing or something that someone else knows besides you. Have a plan. I would encourage family members to go to doctor's appointments with their loved ones. I mean, I would rather my wife comes to mine because she's got a better memory than I do. And she can help and we can work through it together because we're a team. You know, create that kind of team atmosphere between you and your parents so that everyone's on the same page.
Great. How would you advise on how to include the siblings? It's a written plan that you share maybe with the siblings as well, so everyone's on the same page.
Yeah, I think so. Or either a written plan or have a team meeting, have a family meeting where you come together and be like, you know, we're getting a little bit older. We want to make sure everybody's on the same page. We want to make sure that everybody knows these are our wishes so that there's no bickering and fighting in between.
How much bickering and fighting? Yeah. Is there anything else you'd add to that list that they should do?
Just to make sure that communication is happening.
Yeah.
Check in. Make sure that your parents know that, not overbearing. You want them to have independence. I want my patients to have independence.
Yeah.
But I also want them to think about the future a little bit because we don't know what it holds.
Absolutely. That's such great advice because which is going to lead us to the next conversation of things gone wrong, right? I first want to talk about, siblings that aren't on the same page. You've seen families, I'm sure, over the years that have been torn apart by their patient or their parents passing away by not having a plan, and it really affecting generations from there on out. Mm-hmm. Give us some examples of things gone wrong to prepare us of why we should do this.
We talked about the IDTs, which more times than not go well, but sometimes not. Because not everybody's on the same page. And I find that as a provider, but also having this family dynamic that I have with my mom who's a widow and dad recently passed, that I sometimes have to step back from my knowledge as a provider and just be a sibling and say, what does mom want? So it's great for us to know healthcare knowledge and medical knowledge. But if we come in guns a-blazing and say, I know everything and I want it done this way, it may not be what's safe because we're biased. Mm-hmm. And we kind of have to stop that bias. And that's what I've seen a lot is that someone's a nurse, someone's an accountant, for example, someone's a contractor. And they all have different opinions, but the nurse typically has the most strong-headed opinions because we've seen a lot. Yeah. But it may not be the best thing for mom.
So even healthcare providers.
Sometimes we're the worst patients. Sometimes we're
be the family member. Don't be the caregiver. Allow the experts. I know you're an expert in your area, right? And I try to do this as a PT. When my dad was in a skilled nursing facility, I'm hearing what he's doing. I'm well, why are you doing this? Why aren't you doing this? And that's not fair for me to say. Correct. Because I'm not in it, right? So now when a parent's in a facility like that, I just go and observe. I'm okay, what's going on here? Tell me your decision making to, help me understand why you made that decision. It's not for me to diminish what you're doing. It's me. I'm seeking understanding.
Correct.
I want to make sure my dad or my mom gets the absolute best care as possible. And I just want to make sure I'm on the same page with you.
Well, you bring up a really good point. Observation when your parents are in a skilled nursing facility is extremely important. I've had multiple family members come in once and try to run the roost, try to do everything possible, try to be well, this is how I want it. And I'm you've been in here once and your mom's been in here for 4 weeks. Come in a few more times. Observe what's going on.
Yeah.
Understand. Talk to the therapist. I would give advice to family members. If you want mom and dad to go home and you want to provide the care for them, go meet with the physical therapist that they're working with. Learn how to lift them out of bed. Learn how to do exercises.
Safely.
Learn how to do exercises with them.
because they can teach you such a better way, right? Because you might think, well, I'm tough, I'm construction work, I'll just throw mom up on the.
It's not
But we
what's
can
best.
teach you the way in which she's going to do the majority of it.
Correct.
And you're going to do the least amount, which actually will help her so much more in the end.
That keeps
Rather
her
than
independent.
you just hee-hawing her over to the chair, you're actually getting her to use her body to do it, right?
Yeah, I think teaching family members is something that I try to encourage in these IDT meetings. I'm like, come in, see how the nurses work with your mom, go to dinner with them, see what they're eating, making sure that it's appropriate for them. Go to physical therapy.
It's going to give you a
with
completely different perspective.
Yeah. Come on rounds with me when I talk to your mom. Like, I have zero problem with this.
Yeah.
But don't just come in one time and try to run and dictate.
Yeah.
Because if you want to know, observe.
Yeah.
If you want to know, listen.
I want to share an example here. My dad had a collapsed lung. He got in a motorcycle accident. Ended up, transferring to another facility, another hospital. They were so focused on his lung that they didn't pay attention to the rest of his body. And I purely just went in to observe. And I really went with a different mindset than I have in the past, because I've gone in as like that dictator. I'm like, what's going on here, right? And start correcting things. Not my place, right? I'm here to be a family member. And then I'm just watching him walk. I'm like, why are you limping so bad? And he's like, well, my ankle hurts. So I asked the nurse, I'm like, hey, does anyone evaluate his ankle? Just curious. No, we didn't. He mentioned his ankle hurt, but we didn't really dig into it. I'm like, well, his ankle's pretty swollen. He's not able to walk on it. Ankle auto rules suggest an x-ray. Has anyone got an x-ray? Turns out his ankle was broken. I recommended it to the nurse, but it never actually happened. They sent him home. Ended up 3 weeks later, his ankle was still hurting. I ordered an x-ray. His ankle was broken. Ended up being a 9-month drawn-out process because we had to go backwards.
Right.
And he had malunion, so the bone wasn't growing back together because he was putting so much weight into it. So it ended up taking 9 months to a year to get better, when that would have been such an easy fix. But that's a great example of be in the moment, just be curious, be observational. Like, even as a normal caregiver, I think someone could have caught the ankle thing, right? But we're worried about life or death, right? He's had a collapsed lung. They barely saved him, right? He was on death's, knocking at death's door, right? So they're concerned about that. The last thing they're worried about is the ankle, but the ankle needs to be attended to as well, right? But yeah, just observe, be curious, be kind.
Well, it comes back to that 2 eyes are better than one. Sometimes we get so focused on something that we forget all this other stuff. And that's kind of how it is, I feel like, with...
Tell us what that silo means. How would you define it?
Silo's just, kind of just silo care, where all you are is focused on the initial problem at first, when we really should open up our eyes and see, yes, mom has XYZ problems we're dealing with right now, but how is that going to affect her in the future?
Yeah. Or
how is that going to affect her at home? I think sometimes, for example, people will come in with back problems. I had a patient recently that, she was so concerned she was having fractures from osteoporosis, which is weakening of the bones in her spine. And she was like, well, I want this fixed here at the skilled nursing facility. I want it fixed because this is the one most important thing to me, is getting this fixed. And I said, no, let's take a step back. Osteoporosis isn't something you fix quickly. It's not something that you're going to get fixed here. It's something you're going to have to work on for the next 6 months at home.
Yeah.
Here, we can focus on getting you up and mobile and helping with your pain management and taking care of that acute problem right there.
Yeah.
But now we got to look at, what are you going to do at home? What are you going to do with therapy? Who are you going to visit as a specialist, to a neurosurgeon? We got all these other areas that we have to also plan for.
Yeah, absolutely.
But if all we do is focus on that one acute problem and forget about everything else, it's all going to catch up to us in the end, and it's going to cause problems.
Yep.
So we kind of have to have a little broad perspective. Mom's here for a back surgery. Mom fell. Dad had a cabbage. Whatever it may be. Great. We know where he's at. He's at step 3 now because he just came out of the hospital. So he's improving. Now let's start talking about these other areas.
Yeah. One last piece I want to talk about as we wrap this up. And I'd love to hear, you did a poll with some people at work. I'd love to hear your results from the poll. Let's actually talk about that first. Then we'll talk about the home health transition to outpatient therapy and what additional resources people have that they don't necessarily know about. But yeah, tell us about the poll that you ran throughout the facility.
So I just, I thought it was appropriate for, these are facilities down in Utah County. I thought it was appropriate. And this is a discharge planner, director of nursing, a Medicare specialist.
Absolute experts in all this.
Yeah, absolute experts in their respective
really
fields,
pay
right?
attention to this. I'm excited for these.
So I asked them 2 questions. I asked them, number 1 was, what is the number 1 thing you wish families or patients knew before being admitted to a SNF? And not only did I ask this to my facilities, I asked this to my fellow providers as well. So I have some of their stuff as
Excellent.
also. Okay. So the number 1 kind of overwhelming thing was that thing that we talked about with Medicare, 100 days. It's not completely 100% paid. Families need to know that so that it's not a whip in the face when they're like, oh man, what do you mean? What are we going to do? Families also, they said the second thing would be, we discussed discharge at admission. And sometimes families are like, why are you discussing when they're leaving?
They just got here.
Right. I'm talking about them leaving when they just got here because we have a time limit. And we got to have plan A, B, and C in place.
There's a sequential order
before they leave. And so don't be surprised if we talk about admission and discharge in the same visit. Not meaning that mom and dad are leaving right now, but I want you to start thinking about it.
Yeah.
I want you to go out and visit assisted livings. I want you to think in their home, go through their home and be like, oh, wait, this isn't safe for what mom just had. How can we fix this? And if it can't be fixed, what's another option maybe that we can do? I want you to start calling private caregivers. How much do you cost per hour to come in and help out? What resources can we get? Dial 211 and get a case manager. Like, I want you to start thinking about these resources right when mom gets admitted. So that was like the number 1 thing.
I really want to emphasize, as you say that, people that are in the situation where you are a full-time caregiver, you're a family member, you're caring for your mom or your dad, and you're doing it full-time. 211 is a great resource.
Yeah, I would imagine the majority of your...
Meals on Wheels, which is like meals coming to the house, actually really pretty decent.
Brilliant, yeah.
Right? They're good meals. It's actually good food. Tell us, rides you can get, from appointments.
Transportation
Tell
back
us all
and
the
forth.
Other resources.
You can get the Meals on Wheels I like because I want to make sure that my patients are well hydrated and have that nutrition, extra protein, things like that maybe they're not getting. Right. They can get a case manager. There's actually there's a lot of senior day centers that you can have your mom and dad go to for socialization, which is extremely important and not isolation. Making sure that they actually have a senior program where other seniors who are retired will come to the homes of your mom and dad and just visit with them.
How cool is that?
While you take a break.
Yeah.
They have other resources. There's just so many resources on there that even I don't know all the resources. But I do know that you can dial 211, ask for elderly care in the state of Utah, and you will be hooked up with a case manager.
With a case manager, and they just go through things that will help you.
Why not look and see what you're already paying for? Yeah. Why not look and see what those resources are? And making sure that you're asking questions. Well, what could I get? Or what does mom qualify for? Yeah. Just so that you have that. Who doesn't want more resources?
Yeah. All right. Suspense is killing me. Tell me the second question.
The second question that I asked here was, let me pull it up here. What is the best way patients' families can help when their loved ones are in a SNF? And a lot of it was active. We talked about this, active participation in discharge planning. Making sure that family is there, not overbearing, remembering we're all on the same team. I tell my patients from day one, if their family's in there, I'm on team so-and-so. Well, you have other patients, but right now I'm on team so-and-so.
I'm on team John. I'm
on
present.
team John. I'm on team Barbara. You're my focus. Right now, you're my focus. And I want the family members to know that's how it is. That's what we try to do. Now, it may not always happen that way in a skilled nursing facility, but in our program, with the post-acute care program with Intermountain, that's what we do.
Yeah.
That's our goal. Safety, Team John, making sure you get to the next place safely and stable, keeping you out of the hospital, making sure that you become medically stable, and focusing on your future.
Yeah. You know, Steve, I was just thinking about this. I don't know what heaven looks like, but what I envision for you is the thousands of older people that you have helped through this decade of work, and them coming and just flocking to you and thanking you for advocating for them, for giving them resources. Like, the dignity that you give these older adults, I can't even begin to describe, right? But the heaven that I see is all these people just flocking to you and hugging you, man, for all the work that you've done.
Well, and it's not even like, I appreciate the compliment. I hope someday I get to see these guys, because I've met some really cool people.
Yeah.
You know, and getting to know their lives and getting to know the things that they've done for humanity here. And I think, you know, the biggest takeaway as a provider, as any provider, I think, is what is that connection we're making with our patients? Does it go beyond our profession? And some may say, well, that's not professional. You got to keep that boundary. And you do have boundaries. But man, if you're not making a connection with people, I think you're in the wrong line of work.
We're missing it.
You're missing the point.
Okay, last piece we got to cover before we wrap this up. Home health, physical therapists. We talked about this issue before we started the podcast. You get home health, physical therapy, and then it stops. What do you wish every home health physical therapist knew?
I wish that they would talk to the other care team in home health. Is a physical therapist calling a CNA about, hey, what did you notice? How did they move during showering? Or how did they move when you're getting up out of bed, and helping them do that? Or with their activities of daily living? Because a physical therapist is only there 2 to 3 times a week as a home health physical therapist.
Yeah.
Are they calling the nurse and being like, are they taking their medications appropriately? I'm seeing this concern. Are you seeing this? Are we on the same page? Calling the family members and being like, have you checked on mom? This is what we worked on. Can I come in and help you teach these to you so you can help mom do them on the days that I'm not there?
Yeah.
And then just evaluating, having that end. And I get it. I was a home health nurse for 10 years.
You're busy.
Along with inpatient.
There's a lot of things.
You're busy. Physical therapies are seeing 20 patients a day sometimes. Like, it's a busy time, right? But those first couple weeks at home from the hospital when you're at home health are some of the most crucial to eliminating readmit to the hospital.
Absolutely.
So are you taking that time, those first couple weeks, to make sure that these patients understand you're A, on their team, you're B, you're concerned about them, and when the time for discharge comes, like we talked, you know what? You're doing really good on this, but man, I see a little bit of deficit here. Let's get you to the next step. There shouldn't ever be just an end. Hospital is not just an end.
Yeah.
It's moving towards the next step.
Yeah, and that's where outpatient physical therapy comes in, right?
Right.
We get done with home health. They're not to where they need to be. You're like, we've worked with you for 3 weeks. How much strength can you gain in 3 weeks, right? Let's build the bridge back to outpatient physical therapy.
Correct.
And our job in outpatient physical therapy, okay, what is the next step now? Do you have a good home program? Are you working with a personal trainer? Are you going to a gym? Let's talk quality of life for the next 10 years, right? Let's build this system up. There's a reason why all these steps exist. It's not to just check off boxes. It's purely to give them the best chance at life. And we're talking quality of life, not just purely existing in the world. We're talking living. If you want your parents to truly live, each one of these steps that we talked about today are going to help them do that, right?
Right.
And even an outpatient, we're always talking about, okay, what's the next step?
Right.
It's not just discharge and we're done. It's like, no, what is the next thing that is going to lead to the best quality of health for you, right?
Well, and I think it's just remembering each of these episodes, we're going to call them an episode in a person's life. Hospital stay, SNF, home health, outpatient. They're just a part of a continuum of good care. None of those things are, we fixed you.
You're done.
You're done. Those are just a continuum of good care. It's a flow. You know, if I say, okay, from the SNF, now you don't need any help at home, more than likely I'm going to see you again in a couple months.
Yeah.
But if I say you're in a SNF, now I'm going to get you home with home health. But you know what? You just had a massive back surgery and you need 6 months of rehab. Home health's going to cover the next 6 weeks. You got a little bit in the SNF and a little bit at the hospital. Now I'm going to get you to outpatient physical therapy after home health. And outpatient's going to get you whatever you need after they're done with you. And there's always a limit because of the healthcare system that we are a part of. But it doesn't mean that we have to limit their opportunity to heal. Yeah. We just find different resources for them. Yeah. That's kind of why we're here. It's a continuum of care.
Absolutely. We've covered so many great tools today, so many things to think about when helping your mom, grandma, dad through this complex medical system. I hope if you have parents, which all of us do, and you're that middle age, that you have these conversations with your parents. So you know their wishes, you know what they want. You've written them down so you're all on the same page. If you run into case A, B, C, or D, like have contingency plans and map those things out and ask good questions. You have a great healthcare team, right? Be curious, ask good questions, have these multidisciplinary team meetings because they're all critical to the best quality of healthcare for the patient. So, Steve, thank you for joining us today, sharing your expertise. Thank you for what you do in the community. Appreciate you.
I appreciate being here. Thanks, Brad.